Chronic pain means many things to many people. It means pain that is lasting for long, or it means pain that is lasting beyond the healing time of an injury, when it lasts much longer than the injury itself. Leading causes to chronic pain are definitely musculoskeletal conditions like low back pain, osteoarthritis of different joints, myofascial point syndromes, fractures, slip and fall injuries, and from the neuropathic or neurological point of view, diabetes, peripheral neuropathies, post-herpetic neuralgia, spinal cord injury, strokes, and all kinds of things. And of course, many people have mixed conditions. And of course, in many people, sometimes the physical injury has healed or is minimal, but the pain itself continues indefinitely. They are more prone in having certain chronic pain conditions, and they are more protected in having others. For example, low back pain and joint arthritis will increase as you get older. Post-herpetic neuralgia increases in terms of its prevalence as you get older. Diabetic neuropathy, as we get diabetes and we live for long years, increases, not necessarily with age, but with the time that has passed. And then there are other conditions that are conditions for younger people, and always age has to come as a consideration when we are looking at pain problems. It depends what's the condition on chronic pain. If your problem is because you have a very bad joint, one single joint, and nothing else, it will limit you in the activities that relate to that joint. If you happen to have chronic pain that is more diffuse or persistent, and it is coupled with other changes, anxiety, depression, isolation, demoralization, failed treatments, it is a much more difficult situation. And of course, it is quite obvious that in those cases, every aspect of life is affected, from employment to personal life, to family life, to relationship with others, to seeking health care and being disappointed, to polypharmacy and everything. So it depends, but as I said, persisting pain that doesn't respond well to treatments takes a huge toll on all aspects of life. If you hurt, that's the first sign. But if you're talking about the subcategory of chronic pain that is associated with very high levels of disability and emotional and cognitive problems, then you look at all spheres of life. What is physically wrong with me? What is emotionally wrong with me? Am I getting very depressed? Am I not able to get out of bed? Am I getting more pain when I'm under stressful situations? How is my pain when I'm in the workplace? Is it getting much worse when I'm exposed to stressors in the workplace? All of these factors have to be taken in account. In other words, many times a person that has persistent pain cannot just look at the pain itself, but his or her own environment and his or her own way with which they cope with life adversities. They start from the very simple ones. If you have a simple musculoskeletal problem, and you can take over-the-counter medications, anti-inflammatories or simple painkillers like acetaminophen, simple things. You can use simple modalities like a heating pad or some support that you can find over the counter, simple things, ice packs. But then as you go more into the pain problem and the nature of the pain problem, then you talk about prescription drugs, You talk about physical or manual therapy, exercise rehabilitation. You talk about psychological approaches with cognitive behavioral therapy and mindfulness-based chronic pain management. And then you go higher up in the ladder with interventional procedures. That means injections in soft tissues, muscles, joints, nerves. And in few cases, you're going to go even further and talk about forms of surgery, depending on the underlying condition. If you're talking about the spine, there are a number of procedures that people will perform called decompression. If you have bone that is pinching on nerve structures in the spine, discectomy, if you're removing a part of a herniated disc, stabilization with fusion, when you want to unite 2 or 3 segments or vertebral bodies in the spine, and you may have to use screws and other hardware. And of course, you have another procedure for persistent chronic pain that is called spinal stimulation. And this is a totally different procedure in the sense that you insert a little bit of a small computer and wires to stimulate a certain part of the spinal cord, so you block the signals of pain. That's a totally different procedure than a plain orthopedic procedure like discectomy, fusion, decompression. So these are more or less the procedures for the spine. And of course, depending on joint pain, you have simple procedures like looking inside the joint and cleaning it up like arthroscopy, all the way to different surgical interventions correcting the way certain tendons go so that you can change the alignment, and all the way to joint replacements like hip and knee replacements were some of the commonest procedures. The first study that was published that showed that there are changes in the brain, particularly in the thickness of certain areas in the brain, was in 2004 by an American group. And after that time, functional imaging, which really has revolutionized the way we look at the function of the brain, has shown that changes occur in the brain, the way the nerve cells consume oxygen, or the way the different parts of the brain connect to each other. Several studies have shown that different pain conditions can change the wiring and the function of brain areas. And such conditions could be conditions that have a biomedical origin, for example, knee osteoarthritis. But there are also conditions that fall under the concept of functional disorders. For example, fibromyalgia or irritable bowel syndrome or temporomandibular joint disorder many times will have persistent pain, but you don't find very much physically wrong with the muscles or the bones. And in this particular case, it's really the brain that has changed very much. And functional imaging has really, over the last 10-15 years, changed completely the way we understand pain, because it has shown significant changes depending on the underlying condition in certain areas of the brain. And as I said, there are different types of functional imaging. You can look at the oxygen consumed by working nerve cells, or you can look at the connections between parts of the brains, and you can even look at the volume of certain areas and the thickness of certain areas and how they change under the influence of a persistent painful disorder, or how they change when you happen to treat that particular disorder, and some of these changes get reversed. Based on studies that we have done ourselves and many other studies, at least here in my program, the number one cause here that we see is car accidents. We see soft tissue disorders persisting for a very long time. And what we see all the time is that the person involved, even in a small car accident, may get very scared. So people don't see the emotional component. They keep treating a perceived physical component but the patient doesn't get better. So when we get them 6 months, a year and a half down the road, well on their way to chronicity, it's all the other things: post-traumatic stress disorder, driving phobia, anxiety, depression, previous issues, because these people were vulnerable from before that continue, and they have been all missed. So if you do not address these issues very early on, if you don't pick up the emotional, the cognitive component, you're missing the boat. By the time people come to us 1.5 to 2 years, they are well into chronicity because we're looking only at the physical part and we have missed all the other part. So looking at the whole person from the very beginning is very important. Another reason is treating well acute pain. If you don't treat properly acute pain, it has been shown that untreated acute pain provokes and contributes to chronicity and with persistence of the pain. So not allowing the transition of acute to chronic pain is very important if you treat acute pain well and early on. For example, post-surgical pain in the hospitals, all of those types of things when we discharge the patient and we don't treat them well, and then we have all kinds of readmissions because we discharged them early and because we forgot to look at the pain component. So that's in terms of prevention. There are other modes of prevention. For example, when you get the shingles vaccine, it's primary prevention. It can prevent many patients from getting the acute zoster, but also it can prevent many patients from getting the post-herpetic neuralgia, which is the indefinite neuropathic pain that may follow many unfortunate acute attacks. So that's a primary prevention. And then, of course, you prevent chronic pain by changed lifestyle, by protecting yourself from immobility, undue weight gain, bad life choices, bad food, maintaining a general state of health and activity, and nutrition is of paramount importance. One of the big problems we have in terms of replacing hips and knees is really our excessive weight. And another thing that is also important is that when there's the very beginning of pain or very beginning signals of some chronicity, that patients are given tools like self-management tools, are having access to other providers than just doctors that can look after the whole person, body and mind together. They learn self-management approaches, they learn things that they can use to prevent, for example, excessive stress manifested as increased pain. All of those things can reduce the pain and can prevent chronic pain in many situations. One of the myths that my patients, the complaints that my patients have is the look good, feel bad syndrome. Many painful conditions don't have physical signs. You don't walk around with one hand or with no leg. You don't have these type of things very often. So many of the pain patients look normal, and that's one of the biggest complaints they have. If you look normal, you can't have pain. That's a very big myth, a very big put down. Another myth is most pain patients fabricate their pain for gains. Well, that is not true. I would like to reverse that and say, are there patients who fabricate their pains for gains? Absolutely yes. I have come a lot across these people over the many years of my career. But are they representing the majority of patients? And the answer is absolutely no. This is where good skills are needed from the practitioners to try to understand all the concepts of pain, understand biomedical causes of pain, but also understand causes within the central nervous system, causes within the psyche of the individual and the environment of the individual.